we are going to discuss about
vessel prepping.
But, you know, I remember when people ask, what is your algorithm to treat SFA? DCB, BMS, whatever. No. What is algorithm to treat SFA? It's first, and we saw it today at 8:30, is to define the access. What is the access? It is radial access, brachial access, femoral, contralateral, retrograde. It's first to define the access. Secondly, is to cross the lesion intraluminally, subintimally, by retrograde access. And the third part, before the treatment, is the vessel preparation. And finally, the treatment, it is DCB, DES, whatever. And so, what I mean here is that vessel prepping is one of the main components of the treatment of SFA. So I have a question for you, Koen. Do you know, so far, the best way to do the vessel preparation?
I really don't know. I really don't know. And I would like to ask it to Marianne Brodman. What is the definition of vessel prep? But she also didn't know the answer, so she said, I don't come.
I don't come.
I don't come. So please try to find a solution. And we mentioned, okay, we're not going to find a solution. We're going to find the answers in the audience. And I'm sure the audience can help us to find some definitions of vessel prep. What do you think?
Of course.
Voilà. Here I have already some UK people. What means in UK vessel prep? What does it mean?
Yes, thank you. This is the $1 million question, isn't it? So in our practice, the vessel prep will probably mean that you achieve some luminal gain to allow for the deployment or your definitive treatment strategy. And whether this is scaffolding or drug sort of eluting or coated technology. This is what we tend to do. Also, we're moving towards the changing the vessel compliance to allow for better response to our definitive treatment as well.
Okay, so I've heard two very important terms, vessel compliance and lumen gain. I think that this makes already some sense. I see here probably some Asian colleagues. Can I ask you about what is in Asia the definition of vessel prep? Can you give me some insights?
Oh, thank you for asking me. I'm Dr. Takayama from the University of Tokyo. So vessel preparation is a really big issue in Japan as well. You know, especially for SFA lesions, because optimal vessel preparation alters the outcome, and it depends, it affects what kind of finalized device you are going to use. So I don't have a very robust opinion about it, but right now it's also a really big issue. Yeah.
You know, there are lucky men in Japan. If I think that you have a reimbursement for atherectomy for Jetstream, is correct? Yeah.
Well, I have to be honest, but yes, first atherectomy device was approved in Japan just this year, but unfortunately, there are a few bad outcomes happened. So right now, it's kind of not in a good situation. But the company is trying to make up for it. And personally, I'm very looking forward to using it safely. But in Japan, for some reason, they did their clinical trials without using distal protection device. So I think our next direction is how to prevent distal embolization using this kind of atherectomy device.
Fantastic insights. Are there some other nationalities who has some other idea about vessel prep, lumen gain, vessel wall modification? Do we miss something? No? Jan? What do you think? I think it still remains very unclear. And so if something remains unclear, what can we do? Asking an expert.
What do you do in routine practice, Koen? as vessel prep tool?
In my practice? Well, actually, I'm following your algorithm. And so my definitive treatment is influenced how I'm prepping the vessel and what is the outcome of the vessel prep. And the vessel prep that I choose is depending on how I passed the lesion. And of course, if you pass soft thrombus, yeah, the vessel prep is Rotarex or thrombectomy device, whatever, thrombolysis. And this is a completely different vessel prep as I'm passing subintimally a coral reef calcified DAS-D lesion.
But perhaps the first message here, before Dr. Stavroulakis' talk, is to keep in mind that we have a strong relationship between the crossing and the treatment. And so the vessel preparation, whatever, POBA, atherectomy, whatever, is strongly related to the crossing and to the treatment. It's very important.
Perfect. So we're going to ask Dr. Stavroulakis to give us the ultimate answer. What is it? And even a more important question, is it really mandatory? Because it's costing money, it is increasing our time, radiation, whatever. So probably we just are discussing about nothing and we can skip it.
Thanks, Koen. Thanks, Jan. So I didn't know that Mariana will not be here today, but so my first poll is about vessel prep, the definition of it. And during the years, I really changed my mind what's the definition of vessel prep. When I started, I was thinking like, I have to do something prior to drug-coated balloons so that at the end of the day, I will not need scaffolds. This was the first impression of vessel preparation that I had in mind. But then while we treat more patients and we develop our treatment modalities and everything, and now I understand that first of all, there's no common acceptable definition, so everyone has different idea what the definition of vessel prep is. But mine eyes is the use of modalities that didn't offer any benefit compared to POBA when they were used as standalone treatment. This can be atherectomy, this can be thrombectomy devices, they can be high-pressure balloons, scoring cut balloons, whatsoever. But now we can use them to increase the luminal gain, change the compliance of the vessel wall prior to definite treatment. And this is not only drug-coated balloon. This can be a drug-eluting stent, can be a bare metal stent, drug-eluting stent grafts, etc. And these methods, as Koen said, of course, they are expensive, they cost a lot of time. That's why we should use them when traditional modalities fail. And we should always keep in mind that when we talk about vessel prep, it's not an entity. There are many different modalities used with different indications, and so they have also different outcomes and results. So when we want to categorize the vessel prep tools, first of all, there's the family of debulking. We have many different atherectomy catheters, laser atherectomy, rotational atherectomy, directional atherectomy, OCT-guided, orbital atherectomy, and then we have the specialty balloons. These can be scoring balloons, cutting balloons, high-pressure balloons, and many different balloons. So these are the first two categories of vessel prep tools. But now we have a continuous development of technologies and vascular modalities, and it's not very easy to categorize all different modalities into family. We have non-permanent scaffolds, for example. IVL, well, it's a specialty balloon, but it's not like only a balloon. We have thrombectomy devices, and as we have a continuous evaluation of the modalities, we also have different infusion catheters where we can infuse with needle medications to the vessel wall, etc. So the family of vessel prep modalities is quite big. It's not always easy to categorize them in one or a second category. The most studied family of vessel prep tools is, I think, atherectomy. And atherectomy, it's not a single modality, but there are many different modalities with different outcomes and indications that are evaluated under an umbrella term, the term atherectomy. Why should we use atherectomy? Atherectomy has some theoretical benefits, especially on the acute setting. We can improve the luminal gain. We cause less barotrauma afterwards with the angioplasty. We can decrease the risk for recoil and dissections. And when we combine it with drug-coated technologies, we might improve the uptake of the drug to the vessel wall. The problem about atherectomy is the data that we have. So we talk about atherectomy, benefit in long lesions, benefit in calcified lesions, but when we we check the trials, for example. This is the definitive AR trial, pilot project, not a big trial. But the subgroups were 24 patients versus 7 or 20 versus 16. So, of course, you cannot say anything about the value of vessel prep based on the current database. And in general, we don't have big randomized controlled trials about atherectomy. And when we have them, most of the times it failed. So what we really need in order to be able to assess the benefits of atherectomy is a big trial for every different device. If it's possible, I'm not sure about it, but the industry has to sponsor big trials, large-scale studies to evaluate the effects of every different modality. Then we have scoring balloons. I won't show you any data because there are no proper data about scoring and specialty balloons. Sometimes you can use them when you have plaques or lesions that are resistant to plain old balloon angioplasty. They have a high radial force. When you use it properly, you don't have such increased risk for dissections. Again, no proper data. That's why I'm not going to show any papers. A promising device was, and still is, the shockwave catheter IVL, intravascular lithotripsy. Well, a standalone therapy didn't offer really a benefit against POBA. But what we saw is that it's a less traumatic vessel prep modality compared to POBA. And now we can treat patients with calcified disease and less scaffolds. But again, if this is associated with theoretical benefit, this is something that we have to see with future studies. I cannot really say that my algorithm is based on a database or a solid data. This is an algorithm that I developed during the last year based on my personal experience. And I really use atherectomy in lesions where I know that plain old balloon angioplasty and scaffolds will probably fail. First of all, instant restenosis. We see this kind of neointima disease. It's very difficult to treat with POBA. Most of the times you will fail, have dissection, distal embolization, etc. And I think that instant restenosis is a very good indication. Long lesions, the reason is that if you go for plain old balloon angioplasty, in the majority of the cases, you will end with a stent from the distal popliteal artery up to the groin. CTOs, we know that in every study, especially in every drug-coated balloon study, when CTOs were treated, the preparation with POBA was associated with increased risk for bailout stenting. Calcification is also a very important indication because most of the times the vessel will not respond to plain balloon angioplasty. And of course, areas where I want to avoid a stent, for me, the most clear indication is the groin. This is an example of a patient with in-stent restenosis, Tosaka 3, complete occlusion of the diploid supera, antegrade retrograde puncture, recanalized the vessel, deployed the distal protection device, prepared with the Jetstream device, and then went for a drug-coated balloon angioplasty with a good result. As you see, this kind of intima we have in in-stent restenosis like a glue. It's not very easy to treat. You might have an acute angiographic result, which is quite good, but I don't think that in the long term, plain old balloon angioplasty and a DCB work. Another important issue is how we treat thrombotic disease. We have many patients that come with acute limb ischemia and other patients that present with acute on chronic. And when you have thrombus, you can, of course, go for lysis primarily. But some patients, first of all, have contraindication, and secondly, when you have a very long occlusion, subacute disease, you might don't have the time. You want to restore the flow quite fast. In these cases, thrombectomy devices can be used, both in acute and subacute setting. Again, patient with superior occlusion, acute limb ischemia, you can remove the vast majority of the thrombus and then go for catheter-directed thrombolysis to reopen the vessel. Long lesions, as I said before, when you have a very long lesion from the popliteal artery to the SFA, of course you can go for plain old balloon angioplasty, you can prepare the vessel, repeat angioplasties, but then the risk that you will end with a stent from the popliteal artery up the groin is quite high. This is for me a clear indication for vessel prep. And the groin, of course, I know that many of us use stents in the common femoral artery. I try to avoid them. It's also a contraindication based on the global CLI guidelines to deploy a stent in the common femoral That's why I try to avoid the stent. We know that when we prepare the vessel quite good, then we don't need stents. You see here a patient that came with a second redo stenosis of the groin. It was a PETS plastic, repeated endarterectomy, and it was a third occlusion of the groin. Perform a directional atherectomy and DCB angioplasty with a good result. So in most of these cases, we talked about DCB, vessel preparation prior to DCBs. But vessel preparation is something that we have to do also prior to stents, and we know it from Supera data that when you prepare the vessel better, then the Supera will stay open and will be deployed much better. And now we run a study where we prepare the vessel with a shockwave catheter and afterwards deploy drug-eluting stents. And now, till now, we recruit the first 25 patients. In overall, the goal is to include 50, and we'll see the combination of IVL prior to drug-eluting stents. In the TBLs, the indications are not very clear. Calcium is a major problem. In this case, I went for orbital atherectomy and DCB angioplasty. To be honest, it's not a very scientific suggestion. We don't know if drug-coated balloon works in TBLs with or without vessel prep. Sometimes when I have repeated stenosis, restenosis after POBA, I go for atherectomy and plain old balloon angioplasty. I used to work with drug-coated balloons. Now I avoid them in the TBLs, even when I go for atherectomy. I think that the TBLs, the main reason is the recoil and not the neointima. What I find very important is a PDVA. We do more and more procedures. A very important step for a PDVA for a lymph flow procedure is to assure that the inflow is excellent. Otherwise, you might fail, the reconstruction will fail. In this case, I try to prepare the tibial vessels and popliteal artery to increase the inflow and then go for PDVA. Aortic indications are rare. Calcium is one of them, and work with shockwave. Not only Japan, but everywhere when you work with this kind of devices, you might face problems, device malfunction, perforation, distal embolization, and aneurysm, and this is something you have to keep in mind. How I select them? Based on various parameters, access, location, type of disease, runoff, and of course the patient. To conclude, we don't have a clear definition. We have different modalities with variable outcomes. Mainly vessel prep devices are used for fempop lesions. We have an unclear benefit for TBLs and aortic disease and a very low level of evidence. Thank you very much.
Great, Konstantinos. So are there questions? I can imagine that there are definitely some questions. I have definitely some. Yes, I see two. First, we start here.
Thank you. Costa, thank you very much. Very illustrative and very helpful as always. So one of the things that you mentioned rightly is that the vessel preparation is the idea is to get luminal gain or improve the compliance, to improve the outcome of the treatment. In your mind, what is the definition of a better outcome of the treatment? Are we talking about procedural technical success rate or on the long term? Because I heard you earlier talking about that we have to focus on patient-related outcomes, as not just a patency or things like that.
So it depends on the patient population that we treat. When we talk about claudicants, then it's primary patency, improvement quality of life, etc. So because we talk about fempop lesions, most of them, then you have to evaluate the primary patency. And I think that you can achieve even good acute results with plain old balloon angioplasty, but we'll know that it will fail. So I don't think that we talk about the acute result. Sometimes, for example, you go for a shockwave, and then you have dissections, and it doesn't really look nice, but you know that it changes the compliance of the vessel wall, and then you can deploy a stent which will open. And this is something that with a plain old balloon angioplasty that doesn't happen. So I think the main goal of vessel prep is to improve the long-term outcomes of the patient and not the acute angiographic results.
Again, this is Toshio from Japan. So I specifically ask you about how to protect distal embolization, especially using those atherectomy devices. I'm also interested in IVL because this is not available in Japan. So do you utilize IVL just as like atherectomy device, like Jetstream, something like that, or is it something different?
So first of all, about distal embolization, it depends on the kind of lesion that we treat. I use distal protection device with all atherectomy catheters that I use, even if they have an active aspiration system. The reason is that I think that all atherectomy devices have the potential to embolize, and the most effective devices are the ones that they embolize more. IVL, it's not an atherectomy device. It has a completely different background. It just changes the compliance of the vessel wall, which means that it turns calcium to a smoother plaque. So you don't have any, and the studies show that you don't have any risk for distal embolization. That's why you don't need a distal protection device with IVL.
Thank you.
Thank you very much for the nice presentation. In fact, actually, you put everything together and how and when to do the preparation of a vessel. But I have a couple of points here. I think when we keep all these things together, I mean, not every person will have the modalities all available. So that's number one. I think when we look at it from the patient characteristic, we look at it from the lesion characteristics, and like what clearly mentioned, how you cross the lesion. Do you think imaging, and I mean by imaging is all modalities imaging, is going to affect our preparations in the future? Either it is intravascular or pre-procedural imaging, like a CT or so.
So I never go to, so most of the times, because there's no never in medicine, but most of the times I will go to the OR with a clear plan, and plan means I need an imaging. So most of the times the patient will have duplex ultrasound scanning, a CT scan, or if he has chronic kidney disease, then MRA. So what's for me important to differentiate, especially for chronic occlusions, I have fibrocalcific disease, or even thrombotic occlusion with organized thrombus or free thrombus. And this is something very important. And you have to do a very excessive workup prior to the procedure, and sometimes also during the procedure with IVUS or extravascular ultrasound. I mean, not everyone has IVUS, but also with extravascular ultrasound, can you detect these lesions that might lead to complications? Most of them are either calcific or thrombotic.
Sizing matter, you know that? And definitely, you know, in routine practice for peripheral, we didn't take care so much of sizing. Cardiologists focus so much about sizing, but we didn't have this experience for SFR below the knee. I think it's important for sharing, to share this point, and you have now 15 minutes with discussion to do it.
Okay. Well, first of all, maybe 2 little comments. I live and work in Belgium. I'm very happy there, but unfortunately for devices, it's a very poor country, so no atherectomy, no IVUS, no whatever you want. So, but we have to treat our patients as well. Secondly, sizing. Well, if you talk about sizing, well, this can mean anything. So I'll try to make some kind of helicopter view to see what we can drag out of this. If we treat our patients in an endovascular way, for me, this is always kind of difficult balance. A difficult balance on one hand, the mechanical, sometimes brutal lumen gain, and on the other hand, of course, we want vessel healing. Mechanical, yeah, definitely, barotrauma, vessel prep. We need to deal with high calcium loads that counteract us. We need recoil dissection. On the other hand, well, there is a controlled regeneration. Of course, in some patients, there is a tremendous inflammatory response, and we try to modulate this with drugs, drug uptake, drug efficacy. And well, in this elegant dance that we try to influence, well, where they meet, I think that's the point where sizing comes into place. Because if we can measure what we are doing, or if we can predict what might happen, well, then we potentially could improve it. Well, we're all aware about this inflammatory process, but what I still have a lot of doubts about, or what I really don't understand, is why are some patients responders and others are non-responders? We all have these patients where we put long stents, and they come back year after year after year with a wonderful result. And then we have these other patients that we stent, and after 3 months, we already see on duplex ultrasound this tremendous intimal hyperplasia. Why? What don't we know? Well, sizing. I think in this afternoon we already heard about IVUS, and I think Fanelli will even talk more about IVUS and the importance there. So vessel sizing and the diameter is very important. Intraoperative evaluation is important because then we can change potentially some vessel prep and tactics, the injury and the vessel device ratio. Well, yeah, I have to admit, although I'm not an IVUS user, we know that with angiography we have definitely not all the information available that we need. There's definitely a discrepancy between the sizing in IVUS and angiography. But then I ask myself, well, you have your CT scans in a lot of patients, you have your ultrasound. Well, this gives us a lot of information. So what are we actually lacking to plan our procedures? Well, for me, well, it's the way how to size. Yeah, what size should we take? Maybe we can discuss later or tomorrow or whatever, how to size on CT, on ultrasound, and then to make this right selection in the materials. Many centers don't have IVUS. I have it on selected cases. And I really hope that artificial intelligence algorithms that I know from some of my friends are working on the calcium load, well, they might help us in this sizing. Today, I have my hybrid room. I have good angiography. I have QVA, but I admit I never use it. I have 3D imaging, but I never use it on the peripherals. And I have my ultrasound, and on occasion, IVUS. And yeah, I have to admit, although we have these wonderful machines, we know from the studies that eyeballing and guessing is not as good as core lab and measuring. So we need more. And yes, potentially IVUS. And why do we need more? Well, it's proven in several studies. Yeah, if you take the Levant trial, for example, when we use optimal wall apposition by selecting the appropriate device according to the vessel's diameter, well, we have definitely improvement. Although it's not always, as I find in different studies, like the collection of all the data in the Medtronic trials on DCB, well, there was less evidence that this ratio was that much of importance. So what are we missing? And what can we find? Well, one of the most important steps in the whole procedure is, I think, the vessel prep. And I found this article, and I was really confused, because on one hand, we have this huge inflammatory response, and this article advocated really strong, aggressive action to prep the vessel. Even 1.9 millimeters on top. So really to have at least 2 or 3 cracks in the circumferential calcium. So at least to open up the vessel and in that way have a long-term better patency. Well, I was confused because, okay, I also crack, but I'm still a little bit in doubt. This was a patient I did last week. Well, we started with a gentle pre-dilatation with 5 millimeters and then did a quite aggressive cracking. But look at the nasty result. There was almost a rupture of the artery, I guess, an ugly dissection. Is this the way we should go with this type of very aggressive prepping? I'm not sure. I'm really in doubt. What is the best way to improve? Well, maybe we should take a little step back and go to the cardiology world and the engineering world. And I found some very interesting papers. Well, this was a finite element evaluation of the damage in the pre- and post-dilatation after polymeric stent implantation. So some messages. Well, first message, if you see the blue line, a vessel prep or pre-dilatation with a balloon in a vessel of 3 millimeters that is undersized, 2.8 millimeters. As you can see, the yellow line is showing if you just put a stent without any prepping or just releasing the stent itself. Well, if you use an undersized balloon, nothing's happening. The stent reaches just its nominal diameter that it can reach. If you go with a balloon that is 3 millimeters, as the vessel is, well, you get a little bit of gain of lumen. If you oversize your balloon and you go beyond the vessel diameter, well, you get a little bit more. But the question is, of course, at what cost? And that you can see already in the lower graph. Yeah, this is the energy that is released, and this is relating to the damage that is done within the plaque. And you see a little bit of gain of lumen, yeah, is corresponding with a large, an exponential growth of energy that is released and potentially giving a lot of damage. And this is also happening not only in the plaque, but also in the vessel wall. And as we know, the more you damage the vessel wall, yeah, the more risk on intimal hyperplasia. And during the vessel prep, well, the energy is mainly released in the media, but afterwards, once the elastic fibers are that much elongated, well, the stent comes in place, and then the stent exerts not only on the media, but also on the adventitia, yeah, a lot of energy with potential damage. So, yeah, what about all this? Can we bring this to the femoropopliteal area? Well, we can. So, analog evaluations were done for nitinol self-expandable stent implantations in the fempop axis. And what we see here in color codes, in predilatation with and without the predilatation on the stenting, is the enormous impact on the wall. What we see is by using a predilatation and then implanting a stent, that we definitely lower the stress on the stent. That's quite logic. Yeah? The elastic fibers are broken, so the stress on the stent is better, so the stent can conform definitely better. But on the other hand, yeah, once the stent is exerting its maximal power, yeah, it's giving a lot of stress on the vessel wall. So then, of course, we come to the well-known principle of the chronic outward force. And in the same article, as you see, with and without predilatation, has definitely an impact on the lumen diameter that we reach and on the stress. I will not rehearse the story of the chronic outward force. I think everybody knows, as long as the curve is very flat, with the changing diameter of the device, of the stent, you exert a very low force. But let's go back to the engineering world again. What about oversizing in the self-expanding stents? Because in my lab, when I put a stent, a self-expanding nitinol stent in a vessel of 5 millimeter, yeah, then I will use a 6 millimeter device, unless it's a braided stent. But what does the engineer say? Well, they mimicked the same situation where they made a patient-specific design of certain femoropopliteal segments, and they put this on one hand on a test bench with real stents, and on the other hand, they made simulation tests. And what they found was quite striking for me. This was not what I'm doing currently in my daily practice. Because in these patient-specific scenarios, what we see is that, on one hand, the oversizing is growing, and the luminal gain is growing with the oversizing up to a point of 1.2, 1.4. And then you see the luminal gain curve is flattening down. The same with stent apposition. If you go up to 1.2, you still have gain, and then everything is flattening up. So, in conclusion, well, the engineers say that we should oversize 1.2 to 1.4, and that will give the best results. This is not what I'm currently doing. So, am I currently undersizing? Should we go for more, or should we rely on the clinical data? Big question marks. And then it gets even more complex if we go in the area of the flex of the popliteal segment, because then you got a lot of bending, you got a lot of torsion, you got compression, you got pinching. We all know the moment that you get in a bending area or you got torsion, well, the chronic outward force, well, the forces that are exerted can definitely go beyond the flattening parts of the curve. And just as an illustration, well, there's tremendous torsion or twist or compression forces, even up to, like, for the torsion, 40 degrees per centimeters when you are sitting on your knees in the garden. So what is happening with all these devices? And what kind of oversize should we definitely take? I think there needs to be connection within the two worlds, engineering and clinical worlds. We all know these videos, and we know that the different devices, they behave in a different way, and they react in a different way on the torsion, the twist, and the compression. So can we bring this, let's say, engineering reality in our daily practice? Well, I think we should at least have an eye on it. And I will not explain the difficult graph over there. It's just meaning that all what is above the zero line means that it's aggravated by the stent. So, for example, at the end of a stent, when the stent is that stiff, you get really a pinching and a kinking. What is below the zero line, is restricted by the device. Well, I'm just going to put some engineering images. I think they speak for themselves. Yeah, if you see certain devices, when you get like 25% of tension or compression, well, they behave completely different. So I think, yeah, maybe we should go more and more for a tailored approach, a specific patient approach. So maybe AI will help us in that. So I think we all know, we have a gut feeling that sizing is very important. Evidence is definitely growing. We need imaging. I don't have IVUS, I hope you all have, but I hope that I will have it very soon. And I think we need to meet the engineers. They will learn us a lot. Thank you.
Thank you so much. I just noticed that you don't speak about CT scan, because also CT scan is a way to make the sizing. Do you do it in practice? And what is the range of SFA diameter?
We do. We absolutely do. And most of our patients, a pre-op CT scan as a regular screening, because we screen from iliacs to the level. But I don't have any, let's say, good clue or algorithm that I can say, okay, this is for me the right sizing. I still struggle. And as you could see in the image that I took in the angio, we took a 5 millimeter and then a 6 millimeter, to my knowledge, quite acceptable as a vessel prep in an SFA, and we got this very nasty result. Although on the CT scan, there was a regular occlusion. So we do CT scans, but I cannot draw any conclusions yet.
If you look about the lesion data and in the study, the range of diameter of the femoropopliteal segment is from 5 to 5.5 millimeter. You agree?
Yes, absolutely. Yeah.
Any comments, question about this?
Even bigger, eh?
It could,
bigger. And that's the question. What should we measure? Out, just lumen. What is the lumen when there is an occlusion? So, yeah, if you have an occluded calcium rock sitting there, what balloon is best for that patient? All questions that I still struggle with.
Kun, any remarks, comment?
No, I'm completely confused now.
Yeah,
I'm completely
we have a
confused.
question.
So it means, as the engineers are
we have a question.
Yeah, but you asked me first.
Oh, excuse me, Kun.
Can you imagine? It's late for the both of us, I think. No. I mean, I'm completely confused because the engineers are saying up to 1.4. It means 40% oversizing. So it means that if we have a 5.2 SFA, and I agree with Lieven, we need to measure it in the correct way. But if we measure it in the correct way and we have a 5.3 SFA, it means that we need to implant a 7 millimeter stent. I was taught not to do this, but to select a 6 as you are doing. So wall positioning on one side, oversizing, cough. I'm not going to sleep tonight. Philip, I bring you the microphone.
Just also what you said today is true for self-expandable stent, not for balloon expandable stent. It's very important. Huh?
Self, yes.
Question?
Nice presentation. So in conclusion, what would you say? What, after presenting all of this, what are you currently doing in your practice now, yourself?
I'm not changing anything yet, no. I hope that artificial intelligence, and I know some groups that are working on that, they're really gathering a lot of data of CT scans to potentially see if we can bring the pre-op CT scans in correlation with the 1-year patency rates. That might help us. Because then we have, of course, the data of the stents or the balloons that were implanted, and maybe that will lead us to stay restricted or go for bigger sizes.
Okay, thank you very much, Lieven, for this great talk. And we can conclude the session, last but not least, with Fabrizio Fanelli. So we had already some information on IVUS, but so now I'm listening very careful to you now. Is it a real need or is it a hype? I want to know it before I'm leaving this fantastic Carousel du Louvre.
You know, it's a late evening, so we make life easy. We can use IVUS. You know. So these are disclosures, and just to show you that I'm a great fan of IVUS. I'm using in all cases. So just to make everything clear from the beginning. But this is the beginning of the study. Now, almost 20 years ago, this article was based on the use of IVUS, but I was shocked because this came from vascular surgeons. So also they understood and they understand more today that imaging is important. It's not only for people like interventional radiologists. But from that point, we underline and we know today there are a lot of limitations about angiography because, according to the projection, we can have a more severe stenosis, less severe stenosis. We are not able to evaluate the correct diameter of the vessel because generally angiography is going to underestimate the caliber. And we know how important it is, the caliber. This is, a paper that was published, many years ago. Again, you see the big difference between angiography and histological, the real caliber of the vessel, And this is something that we have to keep in mind when we are going to select our device. This was another paper in 2010, by some authors that evaluate, the comparative evaluation of angiography versus IVUS. And you see the differences in terms of caliber evaluation, diameter evaluation, but also in terms of plaque characteristics, because this is the other element that we have to keep in mind. Which is the lesion that we are treating? We spoke about, tailored program, tailored devices for each patient. So all this information are coming from the IVUS images. So IVUS give you a lot of information: dimension, plaque morphology, plaque diameter. Also if you perform a recanalization, we know exactly using IVUS we are subintimal and luminal. So IVUS also guiding our strategy and our treatment modality. A couple of examples to convince you, I hope. This is, for example, degree of stenosis. Angiography, we can say this is 30% of stenosis in the AP projection. IVUS, you see, this is more than 50%. So you change completely the strategy. This is a good, nice end of the procedure, in my opinion. IVUS, I have to work more in that area. It is the stent evaluation. We deploy the stent that looks pretty nice deployment, and then with the IVUS, you realize that you are not reaching completely the arterial wall. So you have to increase the caliber of the stent, maybe also in the correct selection before the procedure. Calcium, the big enemy. The good thing of IVUS, there are no artifacts. You see, this is a 360 distribution circumferential in the vessel wall after lithoplasty or lithotripsy. Nowadays, you can see there is a nice channel that we created with the IVL. A lot of information that are coming using the IVUS. Also dissection, we spoke before. This is also to understand better the grade of dissection. And Kuhn asked me how we can evaluate dissection. Here is the answer. You see, IVUS is able to evaluate from 4 to 6 times more dissection than angiography in FEMPOP region and more than 4 times below the knee. So this is something that we have to keep in mind every time we want to reach a nice target outcome at the end. And this is, how they use the IVUS to perform the eye dissection classification in 6 grades. That is, interesting to define better, the outcome after the procedure. There is also something important regarding the plaque geometry, because every time we perform a dilatation, you see the stenosis before, and then on the angio, we have a nice vessel shape. But if you put the IVUS in, you see before and after that the material is still in place. We are just squeezing on the arterial wall. And this gives you information about how much material it is within the vessel lumen, and if this can be the reason of a recoil, during the follow-up. And then, obviously, using atherectomy, you see here before and after the atherectomy, the huge amount of calcium, and then the luminal gain. So we also understand when to stop, if the atherectomy or the vessel prep is enough before the final treatment of the lesion that we treat. Some data just to support these images. This came to a couple of years ago, is the use is a prospective, single center randomized trial, 150 patients, one-to-one randomization between angiography plus IVUS. Here there's the big difference in terms, of freedom from binary stenosis between the combined use of imaging, 72% versus 55% just for angiography. And what is important, you can see here, in the bottom, is that the strategy was changed in 79% of cases. This means that when you perform a pre-treatment evaluation with CT angel, MR angel, or duplex, you have in your mind and define your strategy. But when the IVUS is in, you have to change, in the majority of the cases because the lesion length is longer, the vessel is larger, or the characteristic of the lesion morphology are different. This is another paper that is going to evaluate the IVUS in the sub-analysis of the Caspicum study. You see more than 800 patients that were evaluated, with IVUS evaluating the 1-year restenosis rate. And you see here the big difference when you compare IVUS patients and those patients where the treatment modality was selected without the IVUS. So all this information stress more the concept that I can invest a little bit more money in my procedure because then I can save money later during the follow-up, but also I can improve the quality of life of patients. Recently, this is in a study that is going to analyze just a small number of patients, but just to see how is if it is there is the possibility to reproduce, the information acquired by the IVUS. And you see here in the bottom that FemPop IVUS measurement shows the stronger inter-observer and inter-observer agreement. And this definitely was not possible with the simple angiography. So in conclusion, as we are working more complex, challenging group of patients every day, we are using more devices, and we know that we have to select correctly the device for each single patient, but also each single lesion is very, very important to understand the characteristics of the lesions. And obviously, IVUS will be very helpful to achieve a better outcome in this condition. Thank you for your attention.
Thank you very much, Fabrizio. I think I'm completely convinced now. So we need to introduce IVUS in our surgical departments.
Well done.
You. Questions, remarks, people that are not convinced yet, who are not convinced?
We have more and more strong evidence about IVUS. It's impressive. Huh?
Yeah. This is something that also impressed myself because we started many, many years ago. Definitely at that time was also not reimbursed, but we were, every time we learned something. And now, it's before IVUS was just a simple imaging modality. Now it's something that can driven your strategy. So now we can talk about, the strategy or the technique related, to the IVUS imaging. And obviously, we know you can save contrast media, you can save radiation, blah, 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 all this stuff that is very, very common.
And also, it could be useful to make some recognition to see where is the subintimal and to make the re-entry at the BK level. We have some cases about this, and it improves the quality and the efficacy of the re-entry level, definitely.
Absolutely. Yep. This is very useful, every time also you don't know where you are. So there's give you a little bit more of orientation and information.
Any comments, question? So Kun, it's time to close?
I think it is time to close. We all deserve a very good beer or a good glass of wine, I suppose.
Wine.
Okay. And
Kun, we are in France, not in Belgium.
Yeah, sorry.
So this
sorry
was
for this.
easy to answer.
I'm a little bit...